Hello, and welcome to a session of digital slide review and sign out. I'm Dr. Lewis Hassel, coming to you from the campus of the University of Oklahoma Health Sciences Center in Oklahoma City, Oklahoma. Our program, a joint venture with the Digital Pathology Association and PATH presenter, known as the Digital Anatomic Pathology Academy, which is available to residents who join the Digital Pathology Association without fee. Great benefit of membership. So our case today comes from the files of the GI Pathology Service. We have a 55-year-old man who has been in end-stage renal failure and recently has noted the onset of some abdominal distension not associated with peritoneal dialysis or other features. And that leads to endoscopy, discovery of some ischemic changes, and ultimately resection. So resection specimen comes to us, and we see here some sections of colon. We can see that there is quite a bit of a surface inflammatory membrane overlying these colonic glands, and so here we see features of what appear to be an acute inflammatory colitis with pseudomembrane formation and sort of explosive or exudative cap of inflammatory cells with fibrin admixed and so forth. And so we might say this is an acute eruptive enterocolitis, pseudomembranous type of colitis. It certainly seems to be affecting the entire specimen here. And therefore, we might begin to wonder about concomitant infection, coexistent bacterial infection, potentially with toxigenic organisms, and so forth. However, as we look at this, we see that there is a clue here in the form of this purple debris that is present within the exudate. And here we see these crystalline structures, quite dark purple in size, variable shapes, with a bit of a sort of a lamellation to them, perhaps we might say, a little bit of zonation, if you will. But generally pretty much the same color and somewhat irregular in shapes, variable sizes, but here you see this nice zonation or scaling of these crystals. These are pretty characteristic of kayexalate, which is a drug that's frequently used in patients who have hyperkalemia, and that's certainly one of the challenges with end-stage renal disease. And here we see it rather widely distributed. So the challenge in this situation is because we know this drug can be associated with ischemic changes, is the reaction pattern here purely one of ischemia and acute eruptive changes secondary to the drug? Or is there an association of the drug and in this case, potentially Clostridia with toxins or other toxigenic bacteria. But it is important to realize that this medication, while not uniformly present in this exudate, is certainly at least a potential bystander or participant in some of the ischemic changes associated with this disorder. So let's talk a little bit about some of the crystal-associated enteropathies. And many of these are drug-induced or drug-related injuries, which may be more common than is admitted or recognized. They can act via a variety of mechanisms, both direct toxins, secondary ischemic induction effects, either due to fluid shifts and osmotic effects, or other secondary mechanisms such as immune mechanisms and so forth. Certainly the most commonly ingested drug would be ferrous sulfate, and that can be associated with a type of gastritis. Kayexalate is probably the next most frequently recognized one, and that can present really at any level of the bowel, from the esophagus on down to the colon. Cholestyramine, a bile-binding drug, can also have a crystalline appearance, somewhat similar to kayexalate, but the crystals here tend to be a little bit more reddish in color, and they don't have that scale or zoning appearance. Sevelamer, or phosphorus, another phosphorus-lowering drug used in end-stage renal disease, can look, again, quite similar to kayexalate, but it tends to be sort of a two-toned crystal with that kind of zonation and some of the same types of shapes. A last one here, not one that I've seen, lanthanum carbonate, which also can be used to lower phosphorus in end-stage renal patients, has a less well-characterized crystalline structure and more often is seen within the superficial stroma lamina propria than out on the surface, as is kayexalate. Here's another example of this, to summarize the morphology with kayexalate. We get this sort of what's been described as the fish scale-like, and I think that's because the zonation in the crystals tends to be a single color, irregular, rhomboidal, or polygonal, and usually quite dark purple. This mechanism of action is one of ischemia, and so seeing it in a setting of potentially ischemic changes or pseudomembranous type of changes is concerning. And obviously the consequences can be quite severe, potentially leading to death in a fairly rapid course in some settings. In other circumstances, we may see a greater degree of recovery. And here's a section of bowel that was resected in a patient with Crohn's disease. And we can see here that there's some chronic damage to the mucosa. We have some ulceration and some inflammation. Not a lot of transmural inflammation, but we do see here within the mucosa these characteristic crystals. And in this case, they've been there long enough to induce a foreign body reaction, as you see here and here. Also present over here, out into the muscularis. So you know there's been damage that's exposed them to potential ingestion. And up here, we can see that they're out again in the lamina propria, submucosa, and here again up here with this appearance here. And again, you see the nice zonation. So they may not have been the primary source of injury in this patient, because there doesn't seem to be an acute ischemic change going on, but rather we're left with the sequelae of the drug later on. So our final diagnosis for today is kayexalate-induced enteropathy with some ischemic ulceration and pseudomembrane formation, raising consideration of pseudomembranous colitis secondary to other causes as well. Well, that's our short case for today. Thanks for joining me. I hope you'll find it useful, and if you like it, you'll comment below. Certainly, please share this with colleagues who may find it helpful. And as always, we invite you to subscribe so that you don't miss future offerings from our channel, which we hope will continue for a good long time. There's a lot of pathology to yet discuss. So until next time, thanks for joining us.